Microphone is on. Thank you. Thanks everybody for being here. I'm very excited about what we're doing today and tomorrow. Today with musculoskeletal care and tomorrow with acute post-acute care, our learning collaboratives with that. I am Peter Esselman. I am, for the next 24 hours, president-elect of the organization and then take over the president's slot tomorrow at the business meeting. So come to that with that. I want to thank initially our moderators here today, Kevin Canero, Jared Cottrell, and our panelists, Larry Frank, Rosalind Wynn, and Chris Plasteris, who are going to get us through this session here, introductory session to really what we're doing this afternoon, too. Let me take you on our PM&R bold journey a little bit and get everybody up to speed on why we're here today and where we've been with that. Several years ago, we had this vision of PM&R Bold to develop a unified vision for the specialty of PM&R. We have taken that into advancing PM&R Bold really with our goal of transforming the specialty in alignment with that new vision. And that's one thing we're embarking on today. Our timeline for this, people hopefully participated in this back in 2016 and 17. We did surveys, we did town halls, we did site visits. We engaged thousands of physiatrists to get information about the specialty and where the specialty is moving with that. Based on those findings, the board got together. First of all, we got a summit together. We got about 50 of thought leaders in the field to come together. We took all that information and came up with a strategic plan for the specialty with that. And you're going to see that in a second. We then took that down to think tanks, kind of a smaller group, working group of 10 to 15 individuals in a think tank to come up with the envisioned future and the strategic plans for those practice areas with that. Then after that, it's time to bring it back out to the members, and that's what we're doing here today, to get back to the hundreds and the thousands of members that are impacted by this and get input and help us move forward with this. So, does anybody not think that we have to transform the specialty with that? We have a great opportunity to influence change with that. With the healthcare is changing, we are the best in team leadership, patient-centered care, holistic care, all those things that the future of healthcare is embracing. We can influence the future of healthcare to appreciate what we do for our patients, improving function, improving quality of life. And if we don't do this, someone else is going to do this for us. So there will be changes in how we practice, and we need to be proactive with those changes. Window seems short. Healthcare is changing rapidly and with that. So we have an opportunity here to step forward and do that. Population health is being defined. There are many definitions, I think, of population health out there. We should embrace that and help healthcare define what population health is and what our role is in population health. And here, the statement I said a second ago, we don't define the future for ourselves. Someone else is going to do it for us. Regulators are going to do it for us, or some other healthcare specialty is going to find their niche where we should be and going to step in and start to own that niche where we want to be. We need everyone in the specialty to identify as the core specialty. We're in blue t-shirts today that we are physiatrists and we are together in this. Whether you do musculoskeletal care, whether you do acute inpatient care, peds, any part of our specialty with that, cancer, pain, we're going to pull all this together and we need to be unified in this and to learn from each other as we continue on this journey. I like the word journey because I've considered this my personal journey over the last 2 years as I've been embracing PM&R Bold and leading it over the last year with that. So let's think of the practice area and translate this vision to your practice area. This is the vision for the specialty with that. Many of you have seen this before. I've seen this in slides only about 100 or 200 times, it seems, at this point. But let's go through it for people that haven't seen it. That the vision is that physiatrists are the essential medical experts in value-based evaluation, diagnosis, and management of neuromusculoskeletal and disabling conditions. We are the indispensable leaders in directing rehabilitation and recovery and in preventing injury and disease. And we are vital in optimizing outcomes and function early and throughout the continuum of patient care. Tag words here: we're essential, we're indispensable, and we're vital. I think we all feel that. We got to make our mark, be bold, and make sure that the healthcare system we work in recognizes this vision for this specialty. So we have come up with envisioned futures for practice areas, and we've worked together to create the one we're talking about today, musculoskeletal medicine. And the envisioned future is that Physiatry is primary care's frontline partner for all non-emergent musculoskeletal care. So think about that as we work through today. We're also tomorrow talking about acute and post-acute care. If anyone in the room is interested in that, come tomorrow. Similar process with that. And in there, our goal is that we're the recognized leader across the acute and post-acute care continuum with expertise in managing utilization resources to achieve maximal patient outcome. Other practice areas that we have evolving, we've had think tanks already in cancer rehab and pediatric rehab. Those will evolve to a special practice area vision, to learning collaboratives with that. We're exploring opportunities in pain medicine as our next one to look at that and form a think tank and move that process along. So this is just the beginning of the process here. So the morning session this morning is us introducing this with our panelists to discuss practice area and supporting models. The afternoon learning collaborative starts at 2 o'clock. Encourage you to participate in that. It's at the Hyatt. We moved it over to the Hyatt so we have a little more flexibility on the room layout and the space that we have there. So remember, walk over to the Hyatt to their conference convention area there this afternoon. Why learning collaboratives? And I am super excited to live through this learning collaborative and the one tomorrow to see this. It really is to get member engagement and to facilitate member dialogue and exchange for you to inform us about where the future should be going with that. We got to make this vision a reality for the Academy, but also all the individual members that are working in musculoskeletal care, and to work together to how to implement that vision throughout all types of practice settings with that. How do we get to here in musculoskeletal care? Well, again, just to reiterate, we got that input from thousands during this PM&R Bold process, got down to 50 during the summit, got down to a think tank of 12 leaders, and it's time to take it back on the road and take it to you and take it to all the members so that they're informed about this and can implement this vision with that. We'll have continued focus group surveys, polls to monitor this process and to inform this process with that. So the check marks there, we created the strategic plan with the input of musculoskeletal experts. We've created a PM&R Bold steering committee with that, with the President-elect chairing that steering committee. The co-chairs for our practice areas, Kevin and Jared, are on that steering committee. We've had one meeting and have another meeting scheduled in the spring. We are in progress aligning our Academy volunteer structure and resources. We're creating specialty brand expansion, strategic coordinating committee to move this forward, and engaging members through these learning collaboratives with that. So I hope you feel engaged. I look forward to your participation, and I'm going to turn it over to Kevin and Jared.
All right. So I want to say Jared and I are both really excited about this process. You know, we're essentially facilitators to get all the input from you guys, and so this session today and the later session this afternoon are really about getting input from you guys. So we want you guys to be active participants in this process. All right, so like Peter said earlier, what's the future of our field look like? Physiatry is going to be this primary care frontline partner for all non-emergent musculoskeletal medicine. So what does that look like in practice? So what does this partnership look like? One, we're going to provide access to patients, timely access to patients that primary care sends us. We're going to be very cognizant and mindful about healthcare costs and how to utilize procedures effectively. Be very thoughtful about when we order imaging, be very thoughtful when we prescribe medications. Again, be a very thoughtful partner. We are going to provide and create primary and secondary prevention programs for musculoskeletal issues. This is something we're going to lead for them. And we are going to empower patients. So we're going to educate patients, give them the tools so that they can be informed decision makers in their care. This will hopefully excite primary care physicians, it'll excite group practices, it'll excite hospital systems to think about physiatry as a place to go to for this type of care. It'll increase the value of shared decision making because we'll be known for that. It'll increase the value of prehabilitation because we'll be known for that, and wellness because we'll be known for that. Primary care providers will be really excited because they get to send their patients to these comprehensive musculoskeletal providers who look at the whole vision of a patient. That's exciting. This focus on value-based care will then set the future in population health. So we'll be developing population health models with primary care and physiatrists being their partners doing that. And it's going to be fun for us. We're going to hopefully have an increased level of job satisfaction. Our patients will be happy. We'll be happy. We'll have greater autonomy. We'll feel like we're doing the right thing for the patient, which also always feels good. And so what do these three models look like? What are three practice models? So the first model is, integration of physiatrists into primary care practices, essentially, and multidisciplinary practices as a partner for musculoskeletal care. The second model is establishment of comprehensive musculoskeletal physiatrist-led practices. So groups of physiatrists getting together and creating a group that's facilitating this care. And then the third model is establishing standalone spine and or pain physiatric practices to help patients with these conditions who are coming from primary care. So Jared's going to talk a little bit about how we got there and what the strategic plan looks like going forward.
Sorry, we're advancing on two different slide decks, so I'll do it this way. Okay, so Peter was good to outline, how we got here. But the strategic plan now has been developed, and it's been through leaders in our field. In one of the things that I wanted to emphasize is this is not a top-down administration. This has been really from within our field. All the input that has been brought forward has been listened to and really developed and eventually reviewed, and the strategic plan approved by the Board of Governors. We're now in implementation phase, and so this is why the PM&R Bold Steering Committee has been developed, and Kevin and I are fortunate enough to lead as the co-chairs here. One of our challenges is we need to address gaps between what is happening today in medicine and our envisioned future. And this is really multifaceted. We want to look at model feasibility. We want to take in what are the best practices now and how can we evolve to take in value, outcomes. We have to measure quality. We have to show that we are actually the valued partner. This is going to require a lot of education, and I'm not talking about education just in our residents, but it's actually education on leadership, practice, and clinical education for us that are in practice already. Obviously, a big component of this is reimbursement. We are all here for paying for our kids' education and life. So we have to be reimbursed, and that includes engaging our insurers and the legislators. Awareness, it's not just awareness of the primary care providers, it's awareness from within. We have to all be unified in this force. And a large barrier, I think, is workforce. How are we going to do this is we're going to create curriculum and resources for all of us. We want to prepare us to embrace, lead, and practice in these new models. We have several committees that are involved with this, and you'll see a repetitive theme here, but obviously this is going to require the medical education, program planning, and practice preparedness. We'll talk a little bit more about the learning collaboratives that Peter already outlined. We need to set a standard of training, and that includes our residents, our fellows, but also training from us that are already in practice to advance the knowledge and skills that we provide to take these models to the next level. This is being taken on by our medical education committee, but also the GME committee. We need to demonstrate our value to our primary care partners. And so there's a large effort here. This includes data accumulation. So this includes our registry, the QPPRC committee, as well as a new specialty brand expansion committee. We need to promote ourselves. We need to promote ourselves within ourselves as far as what we do, but we also need to promote as valued partners to the system. And this is, again, a key area where the Specialty Brand Expansion Committee is going to be involved. And we understand that this is not just about communicating to primary care providers in our own communities. It's about the global education and going to a national level with our primary care providers and their organizations. And we're going to launch and support these learning collaboratives, first of which is today. And so with this is how we take information from you and take this back to the steering committees to determine what kind of resources can we put forward to support you in these efforts. So what is happening today? So now we're going to hear from three panelists that have been identified as really three different practice patterns and how they have envisioned the future and how they've implemented it in their practices. This is what has been happening. It's not like bold has been placed onto them. This is how they've naturally done this. And then this afternoon is our first collaborative, which we certainly would encourage you to attend and go out and recruit friends that might be interested. Actually, friends that aren't interested. We'll take them all. And then we're going to have group discussions, and then this will be held forward with Phys Forum. And I've been working a lot with the technology side of this. It's been pretty amazing. So all Phys Forum positive input is going to come to my email, and the negative stuff goes to Kevin. It's really great. So with this, let's get to the fun stuff. Let me introduce a few folks. Larry Frank, Rosalind Wynn, and Chris Plesteris. Again, I'm going to let them talk about their practices and how they've evolved with this.
If you guys have questions as this is going on, please jump in and ask questions. We want this to be two-way.
Can you hear me? Can you hear me? Just speak very loud.
Which one you want to do third? Is the mic on at that table, sir?
Can you hear me?
I don't know if the mic is on.
The light on,
Yeah.
1, 2, 3, testing.
we just talk loud.
We may have to do the interpretive dance. Sorry.
No, it's not for that. No. We go with our interpreter. I can hear you.
Do you guys want to just, you guys can, I think it'd be easier if we did that.
Hello.
There you go.
Good job.
All right, there you go.
Good morning, everyone. I'm Rosalind Wynn. I practice at Baylor College of Medicine in Houston, and I joined Baylor in 2014. Prior to that, I was in practice in Boston at Spalding, and I went through residency, fellowship, and then became an attending over there and stayed on for about 4 or 5 years before moving to Baylor, and I've been there for 4 to 5 years as well. I'm currently the medical director of non-surgical sports medicine, and we have a multidisciplinary sports team over at Baylor that incorporates family medicine sports, orthopedics, a physical therapist, athletic trainers, and physiatry, of course. So our model has evolved over time. When I first started at Baylor, the program was not yet in existence. We were in talks of forming a multidisciplinary team. But over the next 4 to 5 years, we started negotiating and contracting with local high schools and colleges. And then we built partnerships with the primary care group and orthopedics. So I perform ultrasound-guided injections and previously fluoro-guided injections. So that was one of my marketing tools to offer the primary care physicians. And then orthopedics would directly refer patients over to us for those reasons. And then for triage, the sports teams with acute injuries, they would refer their patients. The athletic trainers would directly contact me, text me, email me, and we'd get them in as soon as possible. So prior to that at Spalding, it was a bit different because Spalding had many sports physiatrists, as you know. Joanne Borgstein, Dr. Borgstein was my fellowship director, and she brought me on, and Dr. Savant brought me on to join the team. And so there I had many different clinics. We had 5 different clinics. Each day was a separate clinic. That included a spine center, a sports clinic along with orthopedics within the orthopedic clinic, actually. And we had joined forces with shared MAs and nursing staff. And we had a concussion clinic, the Mass General Youth Sports Concussion Clinic, which we actually started with under the leadership of Dr. Zafont. And that was multidisciplinary as well. We joined forces with neurosurgery, with sports psychologists, with neuropsychologists, physiatry, of course, and family practice. And so that evolved over the several years that I was there. The spine center, we partnered with the interventional spine group in PM&R, obviously, I guess that's part of my team, and the anesthesiologist in the pain clinic. So we offered a variety of different skill sets to them. So I think some of the important factors in building my practice, because I had to essentially rebuild when I moved to Houston, and Baylor has somewhat of a private practice within an academic setting. So we were essentially out there marketing ourselves and building our own practices. And I have 2 children, therefore each time I was on maternity leave, I had to rebuild and get my name out yet again. And so several times of experience with that. So I think some of the key factors is having good accessibility, as in making yourself available. I offer add-ons for lunchtime or after hours, and I try to communicate directly or make myself available via email or text with the primary care group. And also we have somewhat of an express care type of build in our clinic, so there's some flex time where we can add on patients. And so I think that's one of the biggest keys, because when you meet with primary care physicians, one of their big questions is, how long is the wait? And so we say, tomorrow, today. And that makes a world of difference to them. Number 2 is making it easy for them. So another question I had from primary care physicians was, what type of workup do I have to do before they come to see you? I said, 0, just send them right over. Literally, walk across the street, send them over, or downstairs. And so that also made a world of difference, because it takes the pressure off of them and gives them the ease of, okay, I don't have to worry about this, you'll take care of it, and you'll take care of it on a timely manner. So part of when I was building up my practice was also meeting with the primary care groups and the orthopedic groups, and essentially FaceTime. I think getting your face out there is more helpful than just sending or passing out business cards or mailing out business cards. So in terms of what worked or what did not work, the mailers oftentimes bounce back or were unopened. As you know, you have a stack of unopened mail or emails. Emails go unread. You're just email fatigued with tens of thousands of emails. And so that was something that did not work, or several things that did not work. What did work, though, was to make myself available to them in their, say, meetings or their lecture series. So giving community lectures, giving lectures to the primary care groups, giving grand rounds to the primary care groups. So that was very helpful because they got to know what I do and they could see what I can offer. And so recently I gave a talk for the Baylor Partnership, which are the Baylor donors. And right after that, I had many trustees and several community leaders come into my clinic. So I think FaceTime is very important, but not just shaking hands, but actually lecturing or giving a useful talk that they find is applicable, practical, it's something they can relate to. And so, say I give a lecture to primary care physicians about stress fractures, and then I offer some physical exam screening tools for them and what to look out for. And then they had approached me afterwards and said, "That's very helpful, and I'll send you patients." Now, so the other strategy was to connect with the coordinators of the clinics, say family practice, private practice groups. And that was met with mixed outcomes. Sometimes they would come back with, "You will need to provide us lunch, and you will need to provide us all kinds of things, hundreds of dollars."
So you brought lunch.
I ended up not doing that one, but oh. And so sometimes you'll be met with that. Within Baylor itself, I went to the faculty meetings for the primary care groups and gave out my marketing materials, which included brochures with what I'm all about, so that if they forget all the things I said verbally, they have physical information, and they said they posted on the wall so that other physicians who could not make the meeting can take a look at them. I also made a referral pad, so a tear-off pad that had my information, what Physiatry is about, what I offer, my educational background, my skill set, the types of injections that I do, the conditions that I treat. And it actually fit on a very small, and I apologize, I meant to bring it, but I think I left it back in Houston. And I could share it with you sometime, but it's basically a tear-off that they can give to patients and hold in their pockets, just like any prescription pad. And they've mentioned that they found that to be helpful because they don't have to explain too much, they don't have to say too much, and you speak for yourself in a sense because they have something to bring home with your name, your contact information, and the information that you have to offer. So that was part of the marketing. And some other strategies I tried that did not work was when I first moved to Houston, I decided to go door to door. And so I actually knocked on individual. I Googled and looked for all the primary care physicians around town and actually knocked on their door, walked up to their clinics, waited for half an hour while they had a gap in their schedule and shook their hand. That was mixed. That the FaceTime helped because it did bring in patients for certain clinics, but then I realized that I needed to get to know my own institution first because as I then realized we did not take certain insurances. And so then it was actually blocked at the call center because we did not take these particular individuals' insurances. So first of all, get to know what you do accept. But it was good networking, and at the time when I first moved out there, I had the time to do it because I was still in orientation and did not yet have electronic access. So those are some strategies that did or did not work. Beyond the other factor that helped me was being comprehensive and thorough, as in going beyond just treating or diagnosing their current condition, but actually looking into aspects of the patient's life that can help with injury prevention. We had a lot of athletes who actually had young children, and so part of what was ailing them was the constant lifting, bending out of crib, and carrying their children or breastfeeding. And so it's identifying things beyond just what you're treating at the time. And so I would document that. I have very detailed notes, send it back to the referring physician, and then they eventually recognize that I'm being comprehensive or trying to be comprehensive and thorough. And they would comment on that in their reply, saying, "Thank you for your thorough assessment." So that also helped build my practice as well. And also a multidisciplinary clinic was helpful in the sense that you get to meet with potential referrers, such as orthopedics, such as neurosurgery, such as primary care from family medicine to internal medicine. I also went to physical therapy centers when I first moved to Houston because I wanted to get to know where I was referring patients to. That turned out to be immensely helpful because when you have PT reps that come and they wear their nice clothes and they have nice business cards or market material. And then when I actually visited the PT center, it was a different patient population or a different type of strategy, or it was too gentle or it was too aggressive. And so looking at the facilities, their equipment, what they have to offer, and meeting with the physical therapist and knowing their skill set was helpful to customize PT to the individual patients. Because what I was finding was some of my colleagues were just referring just globally to this one place because the rep was very aggressive and giving a lot of materials and freebies. But then the patients would get turned off by the physical therapy center. They were not getting better, and everyone's frustrated as to why they're not getting better. And just a visit just helped me realize exactly why. This strategy is not working out. I don't see this is going to work. So then I could match it up properly, and I also got to know the physical therapist who ended up actually referring patients to me. And it was from, say, their primary care physician referred to PT, they were not getting better. And they would say, oh, I know a sports physiatrist who you should visit. And they get a lot of feedback, too, from, say, my patients when they work with them for an hour twice a week. And so they know what we're about, and so you find a good match, or you find a partnership. The other areas would be athletic trainers. So I linked up with athletic trainers both in Boston and in Houston and gave my cell phone number out so that they can text me if ever they needed me. And that brought in referrals as well. I also, during orientation when I had time, I also went to massage therapy centers, acupuncturists, to say soccer leagues, and even a dance studio. And with that, that also brought in referrals as well. Again, some were met with, we don't take your insurance, so that was something I should have gotten to know first before I went to market out myself and put myself out there. But that's also something you could work with your institution and then get them to realize that there is a big need for this insurance, to accept this insurance. So multidisciplinary helped with my practice in that I can get direct referrals because it's FaceTime essentially. We have multidisciplinary conferences. I'm sorry, this is not working anymore. Multidisciplinary conferences where we'd have cases that we discuss along with radiologists. And so that's another marketing tool as well. And that was very strong in Boston, where my clinics at Mass General, Newton Wellesley, and Spalding, it was very academic, so we had many multidisciplinary sessions with a radiologist. And so that's something that you could let the PCPs know that we discuss it directly with other disciplines. And then the patients don't have to bring their records to this place, bring their records to that place, because they know that you are going to already directly have close communication behind the scenes, and they like that. So I think I covered most of the points that I was going to cover, so I'm going to pass it on.
Go ahead, Larry. Oh, sure. A question, yeah.
So the question was, I mentioned stress fractures, and did I order DEXA, and did I screen, did I step on their toes? So I think that also goes back to having a good relationship and open communication with the primary care physicians. So there are times when I would say, are you going to be seeing your primary care physician? Are you having an annual physical? And that may be a good time to discuss a DEXA or vitamin D check. Or if they're already seeing endocrinology for whatever reason. But yes, I would order it myself and then let them know, or I would ask them directly. So if you have their email address, or if you have direct connections, such as for anybody using Epic Health, the electronic health system, you can send messages to the primary care team. And so that way you could still respect the turf and respect territory and still get it done without without invading territory. But I do try to be comprehensive, so you're exactly right. If there's a stress fracture, I look beyond. I look at their biomechanics. I work with a physical therapist, which at Spalding we had physical therapy centers at each of our clinics as in directly connected. In Houston, it was a little bit more difficult, and that's why I was more used to just walking into the PT center and watching what they're doing and helping. So that's part of why I went around town and visited the physical therapy centers. And so biomechanics was hugely important because if their biomechanics are not corrected, they will continue and they would return to you with stress fracture after stress fracture. So on the one hand, although that's good for business, it's not great for patient care. So you have repeat patients. But my goals were to get the patient better and they can move on with their life. And so that turned out to be more helpful because what the outcomes of that was word of mouth. So a major part of my practice was actually word of mouth. So an individual would tell their colleagues, their coworkers, their mothers, their fathers, their friends, their siblings, their offspring. And so I would see families. I would see entire families, or I would see, say, faculty, and then I would have a stream of all their colleagues, and I would see in an entire, say, ENT department or something like that. But I mean, that said, there of course were hurdles. There was a lot of ups and downs in order to get there, and there still are. I think the other part of this is to try to distinguish yourself from others, as in, if you choose not to be a pain clinic, then you have to make yourself clear, because if you open the doors, then that opens the doors. And I saw that in myself in the past several weeks, because apparently one of our physicians in our group is listed on an insurance company as a pain physician, and so the outcome of that, I opened a clinic on one particular day, and then all of a sudden it filled, which was unusual within 2 days. So I took a look at it. It was all new patients, but it looked like it was for opioid management, and that's not what I do. And I've essentially built my practice so that I do not do that, and I made it clear to PCPs and to all referrers, and I actually do have that on my referral pad, that in a sense, I manage pharmacological management and medication management, but not chronic opioids, directly, literally on there. So that puts out a clear message. So then we looked at our call center, and there was turnover there. It was actually new call center staff that was not triaging. And so we essentially worked on that, tightened our belts, and worked on triaging better. So I'm sorry, this is going off on tangents, but a long-winded answer to, along with several tangents to get there. But essentially, part of it is shaping what you are about and making sure that they know, the community, your referrers know what you do and what you don't do.
I ask a question? It sounds like in your multidisciplinary clinic, which is a great model, and you're a great model for marketing and everything, that you maybe work with sports medicine doctors who are family medicine trained?
Yes.
And how does that work, and how do you figure out who's seeing who's patient and what's competition like?
That's a great question. So we have a family medicine sports physician who I built a close relationship with, and so it is a tricky area, but we've established ourselves as he likes to see heart and lungs, which is very lucky for me because I prefer not to, and I prefer to see the musculoskeletal system. So he does do screening for musculoskeletal. Then when it becomes beyond that, such as ultrasound, needing an ultrasound, diagnostic ultrasound, or ultrasound-guided injection, that's when, and he does not do that. So we built our niches in a sense. So with orthopedics, it's also similar to that, territory-based, but I think if you build yourself as, okay, this is my unique strategies, this is what I do, such as I look at biomechanics, preventive strategies, I spend more time with patients, then, and the orthopedic surgeons are quick, they only have 10, 15 minutes, then you can work as a team, as in they do the initial, if the patient came into them first, the acute, and then they send over to us for more long-term management, which turns out if you do it correctly, it doesn't turn out to be long-term because the goals are to get them better quicker, and that's what they're looking for. for family medicine, so we built a good relationship in that we directly communicate with each other in person. So he would walk over to my clinic, or I would walk over to his clinic. We'd text each other or email each other about certain cases. And so we established what territory is what is my territory, what is your territory. But then also we try to be open so that, and also offer referrals. As in, I had a patient, an athlete come in, but the blood pressure was high and it's been out of control. And so can you please help with this? And so we can build on each other's strengths that way. Any other questions for me?
All right. My name is Larry Frank. Thank you. I am old, and so I trained last century. And I'm a musculoskeletal medicine person. I did a fellowship. I believe there was probably 10 people before me that I know that did a fellowship in what it was formerly called Spine and Sports, and has morphed into sports alone or pain alone, and now it's kind of coming back to spine and sports as well. So way back in the beginning, I started off after my fellowship being asked to contract with an orthopedic group, and as opposed to now, I mean, I still think that everybody needs to kind of market themselves, like, who are you, what's your value? Back then, nobody knew what to do with a physiatrist, how to pronounce it, what to do with it. You know, I showed up to say, who do you, like, what do you do here? Who are you? What do you want to see? And so I said, well, I see spine and just the same patients that you see. And I said, well, you know, can't really see the same patients that I see. I said, well, you know, just send me who you think I should see. And so something started happening where I started seeing a lot of bad patients. I saw the patients that everybody else saw and couldn't do anything with. So I was the last referral. I was the last, like the 10th referral. And so that was just not, I didn't like that. Those are not the kind of patients that I wanted to see. So it was interesting because I was kind of, at the time, I don't know if you guys still feel this way or act this way, but I felt like I was buried inside this big juggernaut of musculoskeletal, orthopedic group. And so I was kind of one that, I got the, whatever settled to the bottom. That's kind of what I got. And so I didn't really like that kind of patient. I didn't think that was the kind of patient that I could actually help. And so that kind of brought on my thoughts, well, instead of me being the last referral, what if I somehow became the first referral? Like, how would you do that? And so way back when, I decided, well, where do the patients come from? Well, they come from primary care. That's where they come from. So I believe on the moniker of the first orthopedic group that I work with, I think I might not have even been on it, or I was on the bottom or something, or hidden somewhere in the second page or something like that. And so I needed to make, I felt like I needed to make myself known to people that would refer me patients, and in fact to become the first referral. So anyway, that's just kind of a little bit of how I kind of came to this. You know, this bold thing was very natural to me in my evolution of my career. So for those of you that know me, or those of you who don't know me, so I have worked in. I've had a strange practice. I've been in private practice the entire time. I worked with a small PM&R group for 3 years. I worked contracted with the orthopedic group for 2 years. I worked as an employee of a neurosurgery group for 11 years, and then I've been in private practice for 12 years as a solo practitioner in my community. And at present, I'm in the midst of actually selling my practice to a local hospital and joining a PM&R group, quote, neurosciences center at our local hospital, all pretty much in the same community. So it's kind of, I've been around and back. Again, a couple of different ways. My practice also has been different because I've had academic interests. I've been teaching residents and fellows since the first day I left my own residency, and so I have actually trained 11 fellows as well, and numerous medical students. So I've kind of had relationships academically. I'm from Chicago, so with a number of the residency programs in Chicago, actually all of them over the time I've been doing this. And so I've kind of had an interesting kind of hybrid type of thing. So getting back to the bold thing, how is that, how did I establish my relationships with primary care doctors? Well, this was so last century that you actually had to call people and visit people. And so I kind of did, and they said, well, what do you do? I said, well, what does a physiatrist do? That's the big question, right? It's the million-dollar question. How do you define what you do? And it's been very difficult. I said, well, I see the same patients that the orthopedic doctors do. And in fact, I specialize in non-operative care, meaning that I'd like to keep people away from surgery if possible. And I'm happy to see them. They say, well, so you're a pain doctor, right? Because again, PM&R doctors do, in my subspecialty, from the paying perspective, from the hospital service line perspective, we don't do anything different than any other specialty, right? Because an anesthesiologist can give you a patient an injection, right? You do physical therapy? Well, no, I don't do physical therapy, but I prescribe it. Well, who prescribes that? What's that? I do EMGs. Well, neurologists do EMGs. What do you really do? It's always been the question. What are you? What kind of animal are you? It's true. And so over time, I've kind of come to the point where I kind of said, well, we've kind of acknowledged that perhaps there is more surgery going on that may be optimal. And I think that a lot of primary care doctors have recognized that. So now my relationship with primary care doctors has borne fruit not just in my practice, because again, as my practice has transitioned from place to place to place, my referrals have come with me because I've been in the same community. So it's allowed me to be flexible to go from situation to practice situation to practice situation, and they're able to stick with me. So that's been very, very valuable. And then that has kind of segued a little bit into being involved with primary care doctors and being involved with a hospital with a robust primary care base. I think has very, very been important in my career, and it should be important to everybody else's career as well, because of the community that existed there. So I started becoming part of the community, and early in my career, I did a lot of things here at the AAPM&R. I learned a lot about how committees work, how people work together, how big things get done. And I just kind of joked I was more famous around the country than I was in my own community. Nobody knew who I was or what I did in my community, but I could run off and talk to wherever, anywhere in the country here. And I kind of used those skills to become ingrained in the fabric of the hospital in terms of committee work and et cetera. So that's also been very, very helpful for me. I don't know. What's my plan going forward for Bold? For the past 11 years, I've had a solo practice. Many of you that are in private practice probably feel the same pressures that I do in terms of maintaining viability of a small private practice because of the conglomeration of doctors into large groups, and large groups basing reimbursement on primary care doctors on keeping patients within a system. So little by little, the doctors in my community have been sucked into larger and larger groups, and therefore my referral sources. And so as time has gone by, I was thinking, well, how can I thrive and survive in the future? Really, the payment changes that are coming up, people lament very, very soon, there's going to be fee-for-service is not going to happen anymore. It's going to be gone. It's going to be gone. 10 years, 15 years, whenever it may be. And looking at the future of payment and advanced payment systems, working together in large multidisciplinary groups is going to be essential for PM&R, because that's how we're going to get paid. So if you're a musculoskeletal person like I am, the only way I'll find value is if I can prove it to a hospital system and be an integral part of that. And so as I'm moving from an older entrepreneurial private practice model into more of a working back to the future, back into a large group, I see that as being the future and being a part of the population management of spine patients, in my case, I think is my future. So I'm just gonna, that was my blabbering. I'm gonna stop, and I'm gonna let Chris talk a little bit, and then what maybe we can kind of just take, because Chris has a similar but academic kind of practice.
And I'll be brief here and then just try to open it up to more discussion. And looking around the room, I think there's a lot of resources here. A lot of people have their career stories to share, so I'll be brief. I trained at the RIC and worked in the Spine and Sports Center for 9 years after residency. I co-directed the fellowship and I helped build the interventional spine program. And then in 2009, I was recruited back to where I did medical school at University of Pennsylvania to direct a Penn Spine Center and run the fellowship there. So I was there for 9 years, and this past summer I moved from Penn to Moss Rehab. So for me, I kind of grew up in a rehabilitation hospital, spent time in a big university system, big medical center, and I found my way back home to a rehabilitation, rehab-centric organization. So that's a bit about me. And I think part of my experience at Penn was eye-opening. So in the big universities, and those of you that are in universities can speak to this, so that there are a lot of different departments, and each have their different budgets and silos and et cetera, and there's some turf wars going on there, which we're well aware of. And then this whole kind of bundled payment thing came through, and they said, oh my goodness, we better form a service line. So of people, how many are involved with some type of service line at their hospital or universities? Yeah, so this is starting to come out everywhere, and boy, was that interesting to sit down with the head of spine surgery, of neurosurgery, orthopedic surgery, anesthesia, talking about putting cats in a bag. That was an interesting experience, and we're trying to come up with a triage system. If someone calls with spine pain, what do we do? The only thing we can agree on was if someone had symptoms sounding like cauda equina, they better go to the emergency department. Other than that, we couldn't agree. And so, that was, and I think, and I would be very curious to hear the others' experience with this, is you spoke very nicely how you collaborate nicely with the family medicine, like what the niches, and the surgeons, they're going to look at that disc herniation, nice big fat disc extrusion, L4-5 with L5 myotomal weakness, and they're going to say, boy, I can't wait to operate. And we're sitting there, oh, it's going to get better. Just leave it alone. We might need to do an injection, but definitely you need to see an excellent therapist. And I think everyone in the room has had that experience. So what do we do with those people, with those patients, and how do we kind of come to the same page? So I don't have the answers, but just some more questions.
Control the referral if you can. Yeah, control the referral when you can. Be the first one to see the patient, the first one. And actually, in my practice, I also have a very, very strong relationship with the emergency department. And I get their patients in within 2 days. So I see acute and hyperacute back pain. I have a very strong relationship with work injury. And when work injury happens, I get the patients in within 1 or 2 days, the availability. So, it depends if you want to see acute and subacute patients, then you got to be nice to those people that send those people to you. If you want to see chronic patients, then you can, have a clinic that waits 6 months and, they don't mind.
So,
yeah.
Those acute patients, does your practice have that bandwidth? And so what do? You're like, okay, it's 4 o'clock, you have, it's your wife's birthday, you have, dinner plans, you get that call. And what I was taught from my mentor, Joel Press, if a doctor calls to say, I got this patient, and they say jump, you say, how high? Yep. And get them in, just as we were talking about. So how do you navigate that when you're kind of your practice is only so big, and how do you get those people in?
That's exactly what I do. I get them in. I don't care what happens. I mean, I mean, certainly I've been lucky. My wife has actually worked with me in my practice for so long, so she understands. She's been the boss, actually, the practice manager for so long. But yeah, you're right. I mean, it's in order to be, if you want to carve something out, you have to sacrifice something. You can't just have your cake and eat it too. So if you really want to have an acute and subacute kind of practice, you gotta, if you're having Thanksgiving dinner and you're a general surgeon and the hospital calls you and says, I got a patient here with acute appendicitis, you have to leave your Thanksgiving dinner. To me, I don't know, I was built that way. That's the way it was in medicine back then. Maybe it's not so much anymore, but that's your job. It's not your job, it's your mission, you know what I mean? It's your vocation. You've been called, this is a mission. If you just sit around and wait for nice stuff to happen, it's not gonna happen. I'm sorry.
A supportive family is what I heard there,
supportive
too.
family? Absolutely, all day long.
So along those lines, if that patient's coming in from a refer and for whatever reason you cannot see them, then you may actually lose that refer as well as it's not good for the patient. I would see the patient and just drop everything and see the patient. So we're often there until 7, 8 p.m. And we actually have a staff member who stays late to help out with that as well. So she stays until 7 p.m. Now, that said, if you don't want to sacrifice your life that way and have more control, then having a good partnership is important. Because say I'm here at this conference, my partner's covering for me. And likewise, so we are available for each other and we have a good relationship. So if it were, I had a very important family event that evening, then I would ask my partner, can you kindly see this patient? So either way, no matter what, it's good to have that established, have the understanding and have a plan in place. Because you don't want to lose, you want to take care of the patient for their own well-being, and you also don't want to lose the refer as well. And along the lines of the ER, another resource is actually urgent care centers. So around Houston, there are many independent private urgent care centers, and so that is a great place to market yourself if you wanted to see the acute, and that is if you want to see the acute. And I see a lot of acute because we work with athletes and just the community, and so we try to get patients in. Accessibility is really important.
So there's a question out there. Yeah.
Not a question, a comment. I've been in a multi-specialty group that was aligned with a hospital system, and the system was real proactive in the injured employees because it was a manufacturing district. So we set up good relationships with all the large employers. Our frontline work injury clinic was nurse practitioner managed, and any patient that wasn't improving within 2 weeks was fast-tracked to us. I was 2 physiatrists and our own nurse practitioner. You really have to manage your scheduler because we would keep a slot open on one of our schedules that was not freed up until 48 hours, so that we always had space to work in those not healing injured employees within 2 weeks of their injury. So that's how we capture the acute care. Now that works well if you have control of your schedulers. Be careful going into a large neuroscience center.
Oh, I know.
2 years ago.
Been there, done that.
Control your schedule or your schedulers. Secondly, it was an eye-opener. But that micromanagement really helped, but you've got to have that dynamic control. It's really a control issue.
Yeah, some people keep spots open in their schedule for acute and subacute patients, knowing that they'll fill it. I guess if you're not that busy, then you just don't keep those spots open, you just take them as they come. So it just depends. I think there's different situations. I think as a solo practitioner with 5 or 6 huge hospital systems around me, I filled up just right. And so, but other people are trying to manage torrents of patients, which is a good problem. But that's what we all want. We want to manage more patients. We want to manage more spine patients as a field in our country and all the rest. That's our goal. So how to manage that is actually part of this bold problem, because really, if you were to say that PM&R doctors are the go-to specialists for all spine care in the country, there's not enough of us that do this, that are trained in the skill set that's necessary additionally for that. So, like you said, managing with triage and having screening systems and SmartBack and using extenders and nurse practitioners trained by you to appropriately handle the torrent of patients is going to be necessary.
So Larry, with the extenders question, I'm curious, how many people in the room have PAs, nurse practitioners in their practice working them? How about fellows? From the university side, when that call came in at 4 p.m., I would say I have an outstanding fellow that works with me. They're going to intake you. I'm going to discuss the case with them later, and I'm going to review your images first thing tomorrow. Often a call to the patient ahead of time, like, hey, I'm so sorry, I got a engagement I have to be at, but you're going to be seen by one of our skilled physicians. I'm going to follow up with this, review your case, and I'm going to be... So there's a lot of different ways to get those people in because we don't have the bandwidth. And I just, go ahead, comment there.
For these acute injuries, most of the time, if it's that urgent or emergent, that's why we have urgent clinics and emergency rooms. Most of the time, if you get a call at 4 o'clock, and you say, I'm on my way out, but this patient will be seen the first thing in the morning, 7 a.m. next tomorrow, I don't think that anyone in their right mind will say no. Couple things to expand your market. One of them is try to find out which is the best way to communicate with your referring provider. Because if you're in Epic and you have 100 notes from referring provider that you need to review, you won't get to all.
I read all of those, don't you?
We do eventually. The challenge is that someone like paging, someone like email doesn't work for me. I prefer actually a message to the message system on the electronic medical record. The other thing is that orthopedic and neurosurgeons, most of the time they want to be in the OR, they don't like the office. So if you actually can be that triage person and help them out and feed the surgeries helps. And lastly, anesthesiologists are usually not great with exam because in the first 4 years of their training, most of the patients are sleeping. And you can be that person that weeds out what kind of injection this patient has.
Those are very good points. Another... Oh, okay.
I'm just curious if anyone with the alternative payment model coming into play, whether with the primary care practices going to ACOs, if any of you had any type of interaction with ACOs or partnerships or discussions, because that is the way your primary care referrals are going to come in the future.
Yeah, I'm involved with an ACO for my hospital network. The ACOs are right now in infantile stages. There are no-risk ACOs. I have no measures that measure me or anything that I do. Although for some reason I get paid like a $60 check because the primary care doctors all maintain their blood pressure measures well. So, but that's really it right now. In the future though, the change will be, when this change is gonna come, who knows, sooner or later? My estimation is probably, when it comes to spine care, I'm not quite sure when it's gonna come. 10, 15 years, maybe, as a guess. But it's coming down the pike. And so the way I market myself to the hospital is to say, listen, again, one of the reasons why I'm joining the hospital is the ability, in my case, the hospital is very, very interested in a population-based spine center care model. And right now, the hospital, and I don't understand this fully, the hospital systems are very, very enthralled with orthopedics and neurosurgery because of the fact that they fill the operating rooms and create revenue for the hospital system. So right now, they're revenue source. When the payment changes, where you get a payment per person in your community to manage the spine care of your entire community, then an expensive procedure like a surgery becomes a payment sink, a loss. So the hospital administrators are aware that bundling and capped payments are coming. And I get a lot of traction talking their language. I'm the only doctor in my hospital that's talking their language. at least in the spine world. And so that's where I kind of see, you know, my ending out my career here, trying to come up with or manage reasonably the spine care population, you know, not doing anything different than clinically than I've ever done in my entire life. But I think that what my hope is, and nobody's quite sure, is that skill set to manage spine patients conservatively will be reimbursable. You can actually get paid for it. Yeah.
Thanks to everyone for a really useful discussion. I had a question related to sort of a topic you all brought up in different ways. I think you kind of identified like a really interesting question about how we define ourselves. I see sort of the flexibility of what we do and sort of our multidisciplinary skill set as an asset to our patients, but simultaneously sort of presenting difficulties in terms of how we define ourselves to our peers and within our institutions. And I'm curious how you guys sort of have approached the difficulties of sort of navigating, you know, this definition, who we are, what we do, especially you mentioned sort of like in terms of service line negotiations, when PM&R departments or PM&R services relative to other departments like like anesthesia or neurosurgery or ortho or family medicine have a relatively smaller sort of personnel and revenue footprint. How do we sort of amplify our voices in that setting when the question of definitions of who we are is sort of hard to, sort of our definition of who we are is sort of hard to get out there in the setting of all this other revenue and personnel footprint that we don't have?
I'll just make a comment to that. I want to say one thing, which is it's fabulous to see so many people in this room. And I want all of you guys to go back and grab a friend and bring them to the Learning Collaborative this afternoon. Because that's where we're going to put the meat on the bones, right? What we're discussing today is problems and what the future is. And now, this afternoon, we're going to figure out how to get there. You've got experts up here who are doing a good job of it, but they don't even know all the answers because they're not all practicing in the future models that we envision. They're practicing in some forms of those. And what we're hoping to do is take all of your experiences, theirs included, and figure some of those problems out, right? But remember, hospital systems, health systems are facing the same things that you are as individual departments or individual practices, moving from fee-for-service to alternative payment models to value-based purchasing. And we want to be ahead of the game. We want to make sure that because we have a relatively smaller financial footprint or manpower footprint, that doesn't mean that our voices aren't heard, that you're not given the resources to explain why Physiatry's impact on musculoskeletal care can not only save them money, but make them money and protect them in the long run. So that's what we'll be doing this afternoon.
I was going to say, even I think our impact will grow in systems because we're managing costly conditions, and if we can reduce costs and increase our value system,
So you need data to prove that.
That's exactly right.
So you got to have somebody start collecting some data.
Yep.
Right? Andy Haig did a nice study showing some fitness initiative. But I enjoy your definition of bold. But when I think of bold, I think of something that's not necessarily safe. When you think of something that's not necessarily safe, it's a really tricky thing because you all nicely presented how to safely navigate the current system, which is really a disaster. Healthcare is a total disaster. We spend more money than any industrial country in the world, and more surgery than any industrial country in the world, yet we're ranked 13th in the world. And so if we keep thinking things based on old systems of, well, let's be part of a multidisciplinary, neurosurgical center, or let's be part of a hospital systems really don't care about any of you guys. And so you have to be careful and you have to be super creative and you almost have to break the whole thing down all over again.
Well, one way you could do it, Jerry, is to kind of say, well, you know, we can be like orthopods, and they all kind of grow. There's like, you know, 3 orthopedic groups in my city of Chicago right now. They're like 400 doctors apiece. I mean, it's amazing. And that's kind of the old-fashioned way of doing it, and being the 600-pound gorilla or 800-pound gorilla and saying, you know, listen, if you want orthopedic surgery services, you got to deal with us. and then we can strong arm and negotiate high prices for the things that we do and kind of take back, you know, our autonomy, et cetera. That's one way of looking at it. But when the changes come, reimbursement changes come, they will be suffering because of the fact that they will turn from a revenue source to a revenue sink. And when it turns to a revenue sink, then they're gonna sink. So, you know, it's just, there's just not enough, I mean, everybody can't do cash pay practices. I wish we could, but not everybody can. And so, I mean, right, absolutely. I mean, I'm selling my practice, Jerry. It's not worth a lot. You know, it's not worth a lot. A dentist practice is worth a ton.
Your case, they're sitting a lot closer to congressional offices than any academy. There's a lot more money and power in orthopedic surgery. It's going to be a long time before that goes away. So our academy will be trying to empower individual physiatrists by collecting data to show how powerful any individual physiatrist is and how valuable it is for any patient to go see them. So I would imagine your
Registry, exactly.
That actually reminds me of a recent experience. So our orthopedic group asked if I could come to their side of the clinic and practice in their group and have an appointment with the orthopedic department. I deliberated about that. It's a good partnership, but then decided, no, I'm going to stay in physiatry. My business card is just going to have the Department of PM&R. Now, that said, the contradictory part of this is that my strategy is actually to build a team with them. So despite that, what I found helpful was to be non-threatening to your referrers, including orthopedics. And so I share patients with them rather than be their competition. And so that, and when you mentioned how do you define yourself, so we define ourselves as a team. I gave a lecture with with our chief of orthopedic sports, and the audience did ask, so how are you different from orthopedics? And we defined it as, I'm part of their team. We both take care of musculoskeletal, and I offer comprehensive biomechanical assessment, evaluation, thorough physical exam, and XXX skill sets or ultrasound-guided injections. And then the orthopedic surgeon laughed and said, and I do the surgeries. So it's basically, we're like a continuum rather than they're orthopedics, I'm PM&R. Even though I just said that I decided to be PM&R and not join orthopedics. But,
Weird.
But I think being non-threatening is also very important, especially when I was marketing to different physicians, including even chiropractors. At first, their stance was very apprehensive. Who are you? You're stepping on my turf. And then when they saw that I could actually offer a sharing of skill sets and a sharing of patient population, then they started easing down. And then we did have a sharing of patients, and then they themselves came to me as patients. So I think part of it is define yourself, but yet be part of the team at the same time.
So we are, I apologize, I see more hands, I love it. Come this afternoon, we're going to continue this discussion this afternoon and have a lot more time to do it. So we're going to have to wrap it up and head to the plenary. And you, like me, are probably curious what's going on over here, and so stop by. This is an artistic rendering illustration of our discussion, so I'm very anxious to see what has appeared on that board. Yeah, thank you all.
Nice to meet you.